Good evening, ladies and gentlemen. Good evening, members of the Pharmaceutical Society of Kenya. Good evening, our senior colleagues, our seniors in the profession who have joined us this evening. I want to take this chance to welcome you on today's webinar, which shall be on antimicrobial stewardship. Today's webinar being our third webinar of this wonderful year of the Lord 2021. And today's webinar is on antimicrobial stewardship. Towards the end of the year, last year, we had also a number of webinars. We had a number of webinars in regards to antimicrobial stewardship. And we are now trying to augment that and to probably overemphasize that, such that we are having this as our third webinar of the year on antimicrobial stewardship. Our speaker for today is Dr. Dorothy Aywak. I will share her profile later on. And this webinar is in partnership with Pfizer. A few ground rules and announcements before we begin. First and foremost, I want to thank you for participating in this session. I want to also pass the regards from the President of the Pharmaceutical Society of Kenya and the National Executive Council, that is Dr. Louis Mashogu, and also pass the regards from our CEO, Dr. Daniela Munene. Participants are muted during the entire course of this session. You're asked to ask the questions via the Q&A tab at the bottom of your window, and questions shall be addressed by presenters on the Q&A tab. We're also going to find that we have a poll for this. We have a poll for this webinar, so kindly also interact with the poll, and we're also going to share the results at the end of the webinar. For PSK members, if not already done so, please subscribe on the PPB portal for the conference, for the webinar, so that you can get your CPD points. CPD points will only be awarded to paid up members. Probably a point to ask, and this is going to be one of the questions in the Q&A. All other webinars are going to be sent. They have not yet been sent. We understand that. They're all being worked on. You're going to receive all your other CPD points. So ladies and gentlemen, kindly bear with us as we work on all other webinars, previous webinars CPD points. To note is that this session is being recorded and will be made available on PSK's YouTube page. Our agenda today is basically on the presentation by Dr. Dorothy Aywak. After that, we're going to have a presentation from Pfizer by Lavender Okech and the question and answer. The closing remarks shall be conducted by the pharmacy graduate trainee intern, that is Ivy Ratemo. Without further much ado, ladies and gentlemen, allow me to introduce our speaker for today, who is none other than Dr. Dorothy Aywak. She is known to some, to a majority of us. She is known to the young upcoming pharmacists. Probably you've not heard of her, but you may have met her in the corridors of the National Referral Hospital, that is KNH. She is an epidemiologist with over 15 years of hospital pharmacy experience. She holds a Bachelor of Pharmacy and a Master's of Pharmacy, Pharmacoepidemiology and Pharmacovigilance from the University of Nairobi. She is a member of various professional associations, which include the Pharmaceutical Society of Kenya, the International Society of Pharmacovigilance, is ISOP, the International Pharmaceutical Federation, that is FIP. She currently also serves as the Secretary of the Hospital Pharmacist Association of Kenya, that is HOPAK. She has been working at Kenyatta National Hospital for the last 15 years, and that's 16 years, since 2005, where besides managing the outpatient pharmacy services, she is the hospital's pharmacoepidemiologist, pharmacovigilant lead, and coordinates the Division of Pharmacy CPD program. She is also a member of the Medicine and Therapeutic Committee Secretariat, a secretary to the Antimicrobial Stewardship Committee, among other responsibilities in multidisciplinary teams. Dr. Dorothy is passionate about building a patient safety culture among healthcare professionals through facilitating various training programs. She is also passionate about training and mentorship. So, ladies and gentlemen, without further much ado, allow me to call in Dr. Dorothy. Dr. Are you there with us?
Yes, Bao, I'm here with you. Thank you.
Stop sharing here, so that now you can take us. I am made to understand that people will want to have time even interacting with the polls. So, Dr. I've stopped sharing my screen. Now that allows you, Daktari, to share your screen, and now take it over from here, Daktari.
Okay, I want to believe I am sharing my screen and that it is clear.
Yes, it is well clear, Daktari.
Okay, thank you. Thank you very much for that introduction. Not much has changed from then. So I think I will just dive straight into talking about our topic for today. Here we just want to look, today we want to look at exactly how do you participate as a pharmacist in antimicrobial stewardship. And here I'm talking about antimicrobial stewardship in general, not as a committee member. So I'm going to depart from probably previous ways that I have shared these talks around AMS and try to relate this to something that might be practical to most of us, or at least you can try and see how you can make it practical. That's the concept of the 8-star pharmacist, which is from the WHO and FIP. So I hope that at the end of this session, you'll be able to appreciate how you can play your role. So I believe I can just go right in and just start by just introduction. I think most of us, I don't know whether I can be able to see the chat, are familiar with the concept of antimicrobial stewardship. And so just to have an idea who the audience I have today is, I would request Mbao, if you could just put the first question, the first poll question. Mbao?
Yes,
Are
I
you
can
able
hear
to
you,
run the
Daktari.
first? Can you run for me the first question just for us to get an yes? So if you could just respond to just giving me an idea, what practice setting are you in? Are you in community or retail practice? Are you in supply chain management, in hospital, in academia, or regulatory? I don't know that all these questions are running together.
We are running together, Daktari.
Okay, so in that case, if we could we'll probably run it again at the end, because I wanted some of this to appear later, and you can give me an idea whether you participate in an antimicrobial stewardship committee or in any MS activity. This should not, it's only one answer you're giving me. So it's either yes, no, we're just starting. So I hope we are responding to this. I just want to get a feeling of who we have in the audience. Are we able to respond? Question 4, you might not respond to it now. I'm hoping that you'll be able to respond to it at the end. Or question 3 and 4, we can talk about it at the end. But if you give me an idea of 1 and 2, have you run the poll?
Yes, Daktari, we are now at 120 persons have already voted.
Okay, so I'm going to give you a minute. So as you're, I hope you have an idea where you are. You should not be trying to figure out whether you're in regulatory or supply chain. But as you're answering, you just want to start by looking at what is the standard definition of antimicrobial stewardship program, because that is going to help you understand what is your role as a pharmacist in supporting one or being a team member of one. So the good long definition is that it's an organization or a system-wide approach strategy for promoting the appropriate use of antimicrobial. And this you're doing using evidence-based interventions. So I'm hoping that by now you have some response so that I can get an idea of who we have. Bao?
Yes, Daktari, we have some response.
I cannot see the response if you can share.
Currently, from my end, Daktari, we have 51% work in the hospital setting.
Okay.
31% in the community setting. Then 13% in the supply chain, followed by regulatory in the 5% and academia 4%.
So at least I'm able to appreciate that we have a large percentage of our audience are from hospitals. So I want to imagine that you are familiar with the concept of AMS. I'm glad that we also have academia and supply chain and community regulatory practice with us, because I'm hoping that we are going to look at the concept of the 8-star pharmacist to see how we can apply it regardless of which practice setting we are in. So I'd say that is the long definition, or rather the more complex definition of an antimicrobial stewardship program. But I want to think of it simply as slide is now not moving. I don't know whether my slide has moved. Yes. This is how I'd like to think of antimicrobial stewardship in terms of, simply put, that is just a systematic effort to educate and persuade prescribers of antimicrobials to follow evidence-based prescribing in order to stem antibiotic overuse and antimicrobial resistance. So all what we said in the beginning is basically you negotiating in your, depending on which practice setting you are in, with those who are prescribers or policy makers, on how you're going to be able to effectively use antimicrobials that you have within your control, within your facility, or the ones which you're responsible for making policy decisions about, so that you can be able to ensure that there is reduced, that you don't have antibiotic overuse, and then as a result, you can be able to limit the spread of antimicrobial resistance. So I say, when you want to make something simple, sometimes Google, Wikipedia can help you just make it simple. So what is AMS? What are antimicrobial stewardship? So there's a document from the CDC which gives you the core elements of AMS. When you're for the majority of the attendees who are in the hospital system, you might have come across this most likely in terms of, and even for those who participated in the CME last year, we went through what are the core elements of an antimicrobial stewardship program. Now I want us today to look at this in a different light, using what we say the WHO FIP 8-star pharmacist. So I will move from this, we'll come back to it again. And now this is how I want us to look at what the role you play as an in terms of antimicrobial stewardship. And the 8-star pharmacist is supposed to be a caregiver, a decision maker, a communicator, a leader, a teacher. And what was added recently was that you need to be a researcher. Before, the concept was 7-star pharmacist, but now this is 8-star. So we are going to look at how all this, we can be able to relate them to the core elements of the antimicrobial stewardship program. So as a caregiver, what are you supposed to do? If we think back to wherever it is you're practicing, if it is in regulatory care, you'll be regulatory practice. Whatever policies you're going to develop are going to influence pharmaceutical care. Even in training, you're going to be training in academia, you're going to be training your students to be able to offer the best possible pharmaceutical care. In community setting and a hospital setting, it's the same. When you're looking at how you're going to be able to manage your patients, what is behind your mind is making sure that they have the best possible outcome. And for you to provide services of the highest quality, you need to look at it from both the aspect of what is the quality of the product you're offering, what are the policies that you have in place to be able to guide the management of that product, how are you delivering patient education. So quality is a big aspect. It's not just you're not just looking at only product, but you're looking at also the regulation, the policies around it, how you actually providing that service, how you're dispensing is also a very key factor to consider when you're looking at your caregiver role. Is the way you're communicating to the patient going to show that you're going to succeed in optimizing patient outcomes. So as a caregiver, you want to optimize patient outcomes, so that, and this is key to making sure that you have effective, rational, and safe use of medicines. And this you don't do in isolation. You're going to work with other healthcare professionals. So if you're in a community or a hospital setting, you might be interacting with the prescribers, with the nurses. If you're in regulatory setting, you'll probably be with other multidisciplinary teams in developing policies. So as a caregiver role, you need to make sure that you're not doing this in isolation, but instead you're working with other members of the healthcare team. You're also going to have to make decisions. I think in the course of our practice day to day, there's always something that you have to decide, even if it is to decide whether or not you're going to be at work on time. So you need to decide when you're having the antimicrobials that you have in your institution, or that you're responsible for making decisions for, or you're responsible for supplying. You need to decide what you have with you. Is it appropriate? Is it efficacious? Is it safe? Are you offering the most cost-effective option? And all these are also going to play an important role when you're setting medicine policy. How are you going to use the antimicrobials that you have within your facility? I hope this resonates with a number of of those who are attending. Then as a pharmacist, you need to be a communicator. In fact, say usually if you're in a hospital or community setting, then chances are you're probably the last person the patient talks to before they go home. And sometimes what they tell you may require you to go back and find other people that they have interacted with in the healthcare system, so that you can be able to advise accordingly or make interventions to be able to improve the choice of care of therapy that they've been given. You need to be able to know how are you going to talk to your colleagues, how are you going to talk to other physicians, how are you going to communicate to patients. Sometimes a patient can come to you and you know they will definitely not require an antimicrobial, or even your relatives, because they know you're in the pharmacy profession. They will just tell you, I have a bit of a sniffle, a cough, or they are worried that they have passed somewhere, maybe they passed outside a hospital and they don't know whether they could have potentially caught corona. And so they are thinking, could they just find some antimicrobial agent they can use just in case? So how are you going to communicate? So be able to take up your stewardship role, you need to work on your communication, work on how are you going to communicate. Are you going to use social media messaging? Are you going to communicate by word of mouth? How are you going to address the rest of your healthcare professionals? How are you going to make sure that they get the message that you have? I like to think of the pharmacist as this blue pin in this image, that as much as sometimes you could be at the end of the chain in terms of when patients are coming to access care, but you're the one who's going to have to figure out, who does this patient require to see the most? Do they need to talk to a counselor? Sometimes do you need to refer them back to the primary physician? Have they been seen by multiple physicians and they have put several other medications which are interacting? And all this is, you're going to have to know how well to deliver care by being a good communicator. Then you're a manager. One of the aspects of the points in the 8-star pharmacy is as a manager. So a manager, you're managing what resources? You have the antimicrobial agents, you have staff under you or working with you. So now how are you going to manage? So you look at the antimicrobials within your vicinity or jurisdiction. What type of antimicrobials, what range are you keeping? What is the quality of the product? How are you ensuring that you are using them rationally? If you're going to start a stewardship program, are you going to talk to your patients are you going to talk to your patients to familiarize them with the stewardship principles? Are you going to give them time? Are you going to give your staff time to be able to undertake stewardship activities? Are you going to work on building their competencies? Because you can't assign people responsibilities without building their competencies. Are you going to develop policies and standards? And how are you going to do this? So as a manager, look at what do you have with you? How are you going to utilize it so that you can deliver the care or the targets that you have with you? So unfortunately, I am hoping I am not talking too fast for people, because I can see quite a number of chat messages, but unfortunately, I cannot see them. So Bao, you'll tell me if by any chance I am losing anyone in the session.
Asante, Dr. I'll inform you of that.
So the other thing as an 8-star pharmacist you need to be is a lifelong learner. Every day you need to find, or at least periodically. I want to thank you for at least taking time. I can see we are 500 of us today, to taking time in an evening to be able to join us today to at least get something about antimicrobial stewardship. It's a topic that has been talked about in several forums, and sometimes you keep wondering whether you have over-talked about it. But I think every day we keep learning something new. We learn something, maybe a new antimicrobial agent. We learn about resistance patterns that have developed. So it is important for you to be able to keep up to date. Like this quote of Michelangelo, that even at 87, he still found that he still has something to learn. So I'm pretty sure none of us is at that age. So we should be able to be committed to be able to maintain our proficiency. And there are so many forums for learning. Besides joining the professional society meetings, there are also several online tools and online courses, many of them which are free, that you can be able to learn from. And you are give an example in the FutureLearn. FutureLearn has some courses on antimicrobial stewardship. The British Medical Journal, if you can also find some free courses on the same. So I would encourage you to also look at these avenues to be able to build your capacity, to be able to build your knowledge base, to be able to understand. And even when we interact also with our fellow colleagues in the industry, pharmaceutical industry, if Pfizer releases a new product, it's an opportunity to know what is it, how does it work, what are the potentials for resistance, what could be which patients would benefit the most. So there's no limit as to where you can get sources of learning. And then you learn. If you want to retain, the best thing you need to do is that you need to teach others. And who are the others? Those who are coming after us, the future generation of pharmacists. Those who are in academia, I want to hope that they're also having in their curriculum the concept of antimicrobial stewardship, among other topics. Also, your fellow colleagues. Today, I hope you will learn a lot of new things. So I'm hoping you will also go and tell your fellow colleagues what it is you've learned. There will be aspects that you'll pick and you'll say that I can use this to be able to provide better patient education. I want to think of one colleague, Dr. Natharwa, who even has a YouTube channel, and he has a lot of content. And see on his channel, he also has content on antimicrobial stewardship. And so it's good when you teach, you end up learning something. As you teach, you're able to retain, and even helps you improve your practice. At least you will not be the only person working in an island, but you'll have shared, and you can work together with others to be able to improve practice. And we say the best teaching is done in real practice setting. So it is good to teach something that you're familiar with. So what you learn today, try and put a little bit of it in practice. Okay, I wish you could put everything in practice, but what we've learned over time, try and put it in practice, and it makes it a lot easier to teach something that you do. The seventh point in the eighth star pharmacist is the leader. Before, this we used to stop at just the point of the leader. That after you have learned, now you need to create a vision. So what do you want to do? If you're in regulatory setting, what do you want to do with the knowledge that you have? If you're in academia, what are you going to do? Is there if you're still preparing maybe a lecture on antimicrobials, what are you going to do to be able to motivate others to understand the concept of antimicrobial stewardship? For those who are in supply chain, so what are you going to do in terms of how you're going to manage your supplies to make sure that you are actually being a good steward even in that post? If you're in regulatory, what policies are you going to develop so that now you can be able to stem resistance and to also encourage appropriate use? And what you're going to do, you have to teach to those others you work with. So you create the vision. This is what I would like us to do in terms of supporting stewardship activities. This is why it is important. And now it is up to you whether you're going to lead that ship to reach its destination, or you're just going to sink your ship. So it's good to look at how can you create high performance pharmacy practices so that your ship gets to its destination. And if it's a cruise ship and you're having everyone coming to join you, I'd like to think of antimicrobial stewardship as steering a cruise ship, because you want to keep coming. When people come and visit, they will see the good practices that you have, the good service that you have, and they go and talk about it elsewhere. And hopefully others can also pick up that good practice and share it with those they interact with. The researcher is one, having a research mind is the last item that was added to the original 7-star pharmacy, so that now it is 8-star, where you want to encourage you to participate in evidence generation. You know about we keep hearing about the problem of antimicrobial resistance. So, I don't have an image now, but there was a time, the Time magazine will talk about superbugs, the concept of superbugs. So what is it that you can do to generate evidence to find out, do you have a problem in your facility, in your practice setting, even in the way you conduct a business? And then you also look at what experiences are you having. I have a colleague who mentioned that she tried to, in the course of engaging a patient, to be able to just let her see that her request for antibiotic was probably not justified, and so now should ask to try and gauge whether really it is justified by interviewing the patient, if it's justified to be able for her to request for the antibiotics. But because we have created the culture that you can just walk in to a pharmacy and get an antibiotic without a prescription, then now we make it look like if somebody asks about whether your request for this medicine is rational, it looks like you are overstepping your mandate. But now, from her experience, I just started thinking, so how is it that we can communicate to patients as a group, so that if I tell one patient that I cannot give you an antibiotic because what you're describing doesn't sound like it is justifiable, that justifies you taking an antibiotic, and they walk to my colleagues' practice and the same message is passed on, because now you know that if you give the same message, then now even when the patient comes, then they know to expect that they will be asked questions about to gauge whether there is any clinical justification for what it is they want to take. And then we can also share, this is what happened when I shared, and this is the response I got back, so that we can work at how can we improve how we communicate to patients, and what is it that we can approach maybe the regulator or other bodies to do to facilitate us to let the patients know that when we are asking them certain questions, to just establish the appropriateness of what it is we need to give them, that it's not being intrusive, but we are actually doing it with an aim of being good stewards. Also, when you generate evidence, you need to use that evidence that you generated to advise on rational use of antimicrobials. And also, it will also help you be able to build evidence that you can be able to give the other members of the healthcare team, because they need to know that this is what I'm noticing. Even if it's in the retail practice, I'm noticing that I am dispensing a very large quantity of maybe a third generation cephalosporin. So you'd want to find out from the others in either community or hospital practice, is that the case? Are we having a problem with the use of a certain range of antimicrobials? Are we noticing that there could be some resistance? Are we noticing some use that we need to look at? And so now we can be able to say that if you find that the sales of, let's say, if I say the sales of cefuroxime are very high, does it mean that the cefuroxime is the only antibiotic that is helping manage probably URTIs, upper respiratory tract infections, and therefore, if you find somebody selling that the most, that is what is supposed to be the best treatment option? Or we can be able to say that we are having a large volume of sales in this cefuroxime, and we need to check whether we could be possibly building resistance to the same, and be able to share that among ourselves, so that now what we are getting is data based on what it is, how we are consuming, to guide how we are going to use the same antibiotics in future. I hope I have not confused people on that, but I have one exercise that I want us to look at to see if that one is going to clarify what I've just meant in terms of unbiased medicine related information. So if you could run the poll again, the question 3. I just want to have an idea if there is a concept of the WHO aware classification of antibiotics, which is described on this slide. If Mbao, you could help to just run that poll so that you can have an idea of how many people are familiar with this classification.
Yes, I've already run the poll, Daktari.
Mm-hmm.
And on question 3, are you familiar with the aware classification of antimicrobial agents? 48% of the people say yes, 31% say no, and there's a 21% that says somewhat.
Hello, Mbao, you say 21% say?
Somewhat.
Somewhat. Okay.
They are torn in between the yes and no.
Between whether they know or they don't know. Maybe they somehow know because the slide is here. But now this is one way of being able to monitor how we use and even control how we use antibiotics. So the aware classification groups antibiotics into 3 main classes. Those ones which should be readily available, or rather those ones which should be accessible. So they'll be up to a lower level facility if you're thinking in terms of the way hospitals are categorized. So up to the lower level facilities, and these are antibiotics which have activity against a wide range of commonly encountered susceptible pathogens. And a number of these antibiotics, mostly they are either penicillins, first generation cephalosporins, will tend to have a lower resistance potential to resistance than other groups. Then we have the watch classifications. This one has the bulk of the antibiotics. There are 110 antibiotics in this classification. These antibiotics, they have a higher resistance potential. And they are also among those which are critically important, and therefore, because they have a relatively high risk of selection of bacterial resistance. Now, this in many words means you watch this class of antibiotics because the chance of them developing resistance is high, and you also use them to manage quite a number of critically important illnesses. And so you don't want to get in a scenario where your watch antibiotics are resistant. Then we have the reserve group. Ideally, this should be available, their use should be restricted. This group has about 22 antibiotics in it. Examples, I think a number might be familiar with colistin, meropenem, tigecycline. There are quite a number, but it has a smaller number. And these ones, you need to be able to really monitor and restrict how you use them. So if you can develop policies, if you can have more stringent ways of monitoring how they are ordered, how they are consumed, then now these are the class of antibiotics that you want to make sure that you don't end up encouraging resistance to them, because they are basically our last line of defense. So one way that we can use this knowledge that we have, because I like to say, unless you use the knowledge you have, then really it is not of any use. I want to give us a scenario of where now, because I know a number of pharmacists here are familiar with the concept of inventory management of consumption, getting consumption data. And so I want us to think of this case of a pharmacy that is monitoring its antimicrobial use. Now, how do you report antimicrobial use? Do you report it in terms of volumes, in terms of how many sales did I get of, say, ceftriaxone? So the most appropriate way of monitoring antimicrobial use is by using what we call the DDD, the defined daily dose calculation. And this one now you base it with if it's looking at an inpatient setting with the number of bed days, or if you're looking at outpatient setting, you're looking at the number of inhabitants. So I think I'll try to open a chat. If you just saw this, like now, as many of you maybe by just looking at this, what I'd like to ask very quickly, I think I can manage to open the chat. Okay, just at least I can see Eunice. So what very quickly would you think of when we have about 9 antibiotics? Tell me what you think about, what is the first thing that comes to mind? Say you're looking at waiting for someone to present this data to you. What's the first thing that comes to mind? I don't know whether I just volunteer somebody, or can you chat so that I don't volunteer somebody who might decide they are cooking at this time? I want to hope I have people following me. So just by if looking at this chart of this range of antibiotics that belong to the access class, what's the first thing you want to ask yourself? Or what comes to mind? I want to really hope I'm not talking. Okay. Elizabeth tells me that there could be ceftriaxone misuse. David is talking about is looking at high cells. Yes, there's a question, why is ceftriaxone at the top? There's a high use of ceftriaxone. What conditions are being managed? Thank you. At least I'm glad that you're picking out that when you monitor consumption, you now start asking yourself, okay, ceftriaxone, yes, is an access antimicrobial, but is it that we are having ceftriaxone deficiency in the community, and therefore we need to administer a lot of ceftriaxone? Yes, you're noticing that actually we have quite when you compare the ceftriaxone use and the other access antibiotics, it is quite high. So it needs to tell you that if you're going to create an intervention, yes, Esther, it does look like misuse, because you're thinking for all these access antibiotics and they're available in the facility, why does this one particular antibiotic have such a high usage compared to the others? And even when it dips, it still remains a much higher usage. So now I want us to look at those antibiotics that are in the watch category. For this facility, they only had the watch category has 110 antibiotics, but this facility only had data for 3 of them. So at least this is clearer. We have this brown line is piperacillin tazobactam. Then below it, we have ciprofloxacin. And then right at the bottom, we have levofloxacin. So for this watch class of antibiotic, is there anything that would concern you when you're looking at this? So I'd like at least to see from just this, for pulsates down to the availability of ceftriaxone, it's also being a second line choice in guidelines. Okay, now I want us to look at in terms of this watch classification of antibiotics. What would concern you when you see a graph like this? I want to hope that when I've opened the chat box, it has not blocked the slide. Bao, can you see the slide without the chat box covering it?
Yes, Dr. The chat box is only visible from your end.
Okay. So I have these 3 antibiotics, piperacillin tazobactam, ciprofloxacin, levofloxacin. What would concern you? I don't know whether we have any people joining us who are in programs. Would anything concern you, or is there anything that you pick out from this? So we have Daphne, Akot, saying that tazobactam use is increasing. There are a lot of Pseudomonas infections. There's misuse, overuse of the last line of defense. Yeah, thank you. I really like this comment from Esther. Is it that we are having a lot of Pseudomonas and that's why we are using a lot of piptazole? So now increased use of piptaz, so probably resistance is increasing. So when you look at data like this, so I want to start thinking in terms of caregiver or in your role as a decision maker, what would you want to? Yes, Dr. Gemini is asking, what is the TASO? I think she's asking, what is the TASO being used for? So now you start asking yourself, if you're making a decision, and this is the consumption pattern you're seeing in your facility, in your practice, even if you're in supply chain, and this is how your antibiotics are being utilized, then you need to ask yourself, is it rational? Are we dealing with Pseudomonas and there's a Pseudomonas outbreak, and therefore that's why we have to have a lot of piptaz? So it helps you to be able to make a decision and decide, do you need to now restrict the use of this, or do you need to go look for find out who is the probably sometimes the causative agent can be a particular very popular professor. So now you find that one only likes to use a certain brand type of antibiotic, and that's why you'll find everyone, to keep the professor happy, they prescribe only one line, but the use is not rational. But when you get data like this and you share it with the other members of the healthcare teams, then it helps them to be able to think about their practice and to at least see, to speculate, and even for the people who are lab, what could be a potential threat. I like this. John Mugomura says quinolones and fluoroquinones are probably less well tolerated, so maybe that is why their use is down. I would also ask myself, could the TB programs, be doing quite some sensitization to limit the use of levofloxacin and ciprofloxacin, so that if you're looking at this data, you'll be telling yourself that, okay, at least we are controlling the use of levo and cipro. We're trying to limit their use to MDR TB. So are you doing a good job? Like I would ask, would you consider that you've done a good job if it's this period, April, June to July, when you see the consumption of the ciprofloxacin has gone down? I want us to look at the reserve antibiotics. This one right at the top is meropenem. Meropenem, and then we have next is vancomycin. I have to apologize that these colors look very similar, but we have meropenem leading and continue to lead all through. And then we have vancomycin seesawing, and then the others are just roughly somewhere at the bottom. The others include the imipenem, teicoplanin, the tigecycline. I'd like to point out, like this one of the carbapenems, we say the terpenem is supposed to be it's supposed to help you spare meropenem to reduce the likelihood that you're going to develop resistance to have carbapenem resistance and organism. So now, if you wanted to institute a policy where you're encouraging the use of one drug to cover a range of infections, yes, meropenem looks like misuse, and it's also considered a wonder drug. No wonder if you're very sick, then we just give you meropenem, even if the sickness is COVID. So if we wanted to introduce a reserve medicine to reduce the consumption of like now meropenem. I'll give an example of etapenem being a carbapenem sparing. Is a carbapenem as well. If you want to introduce that so that you can reduce the use of the meropenem and imipenem, and then you find you're not using it much, but your use of meropenem is going up. So you start asking yourself, when you look at your role as a manager, what do you need to tell the other members of the healthcare team? Do you need to deploy staff to the area where this usage is excessive, to be able to monitor consumption? What resources do you need to allocate in your facility or in your practice so that now you can be able to stem this rising use of reserve antimicrobials? Who do you need to teach about the good practices? And if they are not familiar with the guidelines, who do you need to target to be able to sensitize them about the guidelines that you have regarding the use of these antimicrobials? Are you communicating effectively? If you have these guidelines, are you communicating them effectively? So thank you. I'm seeing cephalosporin misuse is at an alarming rate. MedReps also play a big role in pushing this product. So I want to really hope that those who are in sales or supply chain, they can also look at this data and also think, what is it that you're doing? So when you look, I know it would be very nice to see a sales graph going up, but what is the implication in terms of antimicrobial resistance? So now I want to tie the core elements of antimicrobial stewardship with the concept of the 8-star pharmacist. The core elements are 9. So if you're looking at leadership, commitment, and governance as one of the core elements, you're a leader, you're a manager, you're a communicator, a decision maker. What can you do to be able to show that you're guiding the process or even supporting the process of ensuring rational antimicrobial use? You, as a caregiver, you play your caregiver role using your drug expertise. Looking at your role, the new role as a researcher, what is it that you can identify in terms of your practice, or even if it is by just looking at consumption practices? What can you identify, report on, and keep monitoring and evaluating to see whether your policy is actually making any difference? Then communication is very key. It is key to all, because you can do a lot of good work, like you can decide to follow your consumption, but if you don't share this knowledge with those who can be able to make a difference or change their practice, then it's not going to be quite helpful. And you need to be able to keep learning new things and teaching these ones. And I think that is a concept, is also will be the same concept like in quality improvement. You learn something new, you teach others so that you can do better. So you learn, teach. I think I have covered how it is you can relate the core elements of AMS. I'm seeing that I'm almost running out of time. The core elements of AMS to the 8-star pharmacist. I want to know the response in terms of the poll. If I don't know whether now we have built our knowledge base a bit, so that, because ideally question 4 should have come at the end, just to have an idea from what it is I have shared today. Is there at least one thing you can pick, even if it is looking at a role that you have not been taking, you've not been actually actively engaging in? Is there one thing that you've seen in that role? Is it that your caregiver role, you think you need to work on how you do patient communication? Have you not been looking for the right data to make decisions? Have you do you need to look at the staff that you have with you and see, do you need to deploy somebody to monitor antimicrobial practices? What is it that, where can you get learning material or continuously engage with new material, new information so that you can build your practice and also share? I would want to hope that the next time there's an antimicrobial stewardship session, that somebody would have picked something that they have learned and they come and teach us about it. And also, you need to lead. You need to decide what is the vision that you're going to have and how you're going to share it. And again, we say now, especially when you're dealing with those in academia, the or those in teaching or the research, that people tend to believe data. So can you be able to gather data from your practice? Okay, so yes, I think that should have been my last slide before we go to questions. But I'd like Mbao, if you could tell me from what it is we've learned today, because I cannot see the poll results. If you can tell me how many people have learned at this or picked one something, or you could even write in the chat box, is there one thing that you think from today's session you can be able to go and apply or do?
Sure, Dr. Dorothy Aywak. So as the members write on the chat box what they have learned to go and do, on the poll results, 85% say yes, there's at least one action they have learned that they can implement. 4% say no, and 11% say it's still Greek. Dr. 11% still insist it's Greek.
So I'm wondering, it's still, now, what percent have learned something? Now, the ones who have learned something, I hope you can teach the others who are still struggling.
85% have learned something, Dr.
Oh, yes. Okay.
Probably from the chat box, they can speak of what they can probably go and implement on the chat box, and probably we should be sharing that towards the end of this webinar.
Okay, thank you. That was actually my last slide. The other slide is just the references. But thank you for the time. I think my time for the session is up. Oh yes, Patrick says the poll was administered quite early. Ideally, the questions were supposed to be coming after a few slides, not together. So I want to hope that the 85% have increased to 100. I want to hope that at least there's one thing you've picked that you can be able to communicate. So, and to again, thank you very much. Sorry, because of the time, it's very dark. So, but those who know me, I think will remember I'm still the same Dorothy who started the presentation. So thank you, and I would like to hand over back to you.
Asante Daktari for your wonderful presentation. I can see even from the comments, Dr. Jaimini Gohil says it's an excellent presentation. So this moment, ladies and gentlemen, without further much ado, let me welcome our main sponsor, our main partner for today, that is Lavender Okech. Lavender, are you there with us?
Hello, Mbao. Good evening, everyone.
Good evening, Lavender. If you're able to now start your presentation, I give you this chance, and probably you leave more time for us to go through the question and answer. Asante sana, Lavender. Karibu.
Thank you. I'm sharing my screen. Are you able to see my screen?
Yes, it's well visible. Probably you can now slide share.
Okay. Just a minute. All right. Is it in the first page from your end?
Yes. Perfectly
Yes.
well. Now you can begin.
Thank you. My name is Lavender Okech. I represent Pfizer. I'm in the anti-infectives and vaccines portfolio. And today, being relevant to your topic, we come whereby we're talking about antibiotics. And the main thing that comes to your mind is what determines my choice of antibiotic. With this, with Zetromax, eradication is accomplished and patient is recovered. For what I'm going to be sharing, Pfizer does not suggest or recommend the use of Pfizer products in any other manner than as described as in the prescribing information approved by local regulatory authorities. When we're looking at antibiotics, we're thinking of something that has high and sustained concentration at the site of infection. With Zetromax, as you can see from my table, is at the sites of the tissue concentration. These are the alveoli macrophages, lung tissues, tonsillar tissues, bronchial mucosa, sinus fluid. You see that there is high tissue concentration of the drug on this all tissues above the MICs of all of the pathogens. This include H. influenza, S. pneumoniae, parainfluenza, and the likes that you can see on this table right here. So MIC, it achieves high concentration at the site of infection that exceeds MIC for susceptible bacteria. The other factor that will definitely determine why you pick, why would you choose Zetromax over maybe probably another antibiotic. Zetromax has a unique proven anti-inflammatory effect. When you look at our graph here, you'll notice that we were comparing this is comparison between a study that investigated the potential anti-inflammatory activity of 3 microlide antibiotics. That's Zetromax, and clarithromycin is what we focused on over here. And you see the number of neutrophils in the area is that with clarithromycin, there's still high number of presence of neutrophils, but with Zetromax, the number of neutrophils was quite low. So with Zetromax having a unique proven antibiotic effect, the concentrations are higher in the presence of inflammation, where drug is delivered to the site of infection by leukocytes. Excuse me. Zetromax produces a significant post-antibiotic effect on gram-positive and gram-negative bacteria. Looking at our chart here, at our graph here, you'll see that we're comparing against Zetromax and clarithromycin. Zetromax has a long elimination half-life, thus extended antibacterial spectrum. The main one thing that was quite evident from Dr. Dorothy's talk was that efficacy is something that you're very key on when it comes to choosing of antibiotics. So in my next slides, I will be sharing these indications and where we come about when we are bringing about the point of efficacy. In my first slide, I'm comparing Zetromax efficacy in cases of upper respiratory tract infections. You can see Zetromax efficacy when it comes to acute ear, nose, throat infections. You can see Zetromax has a 97% proven efficacy against coamoxiclav and cefaclor. And you know, in this, what we are trying to make very evident is that treatment for 3 days is faster and more effectively clinically than standard treatment with amoxiclav or cefaclor in acute infections of the ear, nose, and throat. Next, we're going to be seeing the success rate when it comes to sinusitis, acute otitis media, and tonsillopharyngitis. We can see that Zetromax has shown comparable efficacy with the existing therapeutic in previous clinical studies, whereby Zetromax is given for 3 days and amoxiclav is given for 10 days in children with bacterial sinusitis aged 5 to 15 years. With this, we see that Zetromax has the comparable efficacy when it comes to this, yet offering compliance, very good compliance in that it's just only for a 3-day, it's just only for a 3-day dose. Let's move to the lower part of the respiratory tract infections. Well, the most common lower tract infection, respiratory tract infections we get is community-acquired pneumonia. And here we're trying to compare how community-acquired pneumonia course of antibiotic regimens of treatments. We're comparing, there were 3 studies that were taken over here in adults, inpatient, in adults, inpatients as well for Risotto et al., and also adult outpatients. And then we're just comparing the short course treatment of Zetromax, which is just 500 milligrams once a day for 3 days, and the long regimen for the other antimicrobial agents. From this, it is quite evident that shorter courses of therapy for community-acquired pneumonia are significantly effective than a longer course, because in that a short-term therapy improves patient compliance, decreases adverse effects, and minimizes the emergence of bacterial resistance, of which we know this is something that we're really trying to fight against. Bacterial resistance is becoming so much nowadays, and we're trying to get to a point where we don't have to be dealing with that. And with Zetromax, with its short course treatment, you are sure that this is something that you'll be fighting against. When you're comparing Zetromax efficacy in lower respiratory tract infections as other microlides, you see the efficacy is equally better. But with Zetromax, it's also not only, because when you're getting to a patient and you don't have time probably to test which specific bacteria it is. Zetromax is ideal for empiric therapy of community-acquired pneumonia in the immunocompetent host. Zetromax is preferred in outpatients with comorbidities such as COPD due to H. influenza when compared with other microlides. When we're looking at the guidelines, you see Zetromax is approved when it comes to the IDSA guidelines, when it comes to the CDC therapeutic working group recommendations for community-acquired pneumonia, for the Canadian Infectious Disease Society and the Canadian Thoracic Society guidelines, and also in the ATS guidelines. Zetromax is well approved in all these guidelines, and we recommend Zetromax to be the drug of choice, the antibiotic of choice for your patients. By the time you're giving an antibiotic, the thing that we're coming to look at is how soon are you supposed to see the recovery of the patient? You don't want the patient coming back telling you that this drug is not, I don't seem to feel better, or I'm not better at all. With Zetromax, the recovery rate for Zetromax is very high. So Zetromax has a more rapid onset of symptom of relief than other antibiotics. Seeing from our graph here, you can see Zetromax has a higher percentage, which is 64. When you're talking about rapid onset of action, and other biotics was just 44. Zooming into this graph on my right, I hope it's also on your right, we are comparing the perception of efficacy. You could see azithromycin is the first one. Other antibiotics, there's amoxiclav, amoxicillin, penicillin, erythromycin, etc. With this blue, extremely effective, you can see azithromycin achieved 40% efficacy when it comes to extremely efficacy, which was extremely effective, which was very high. Also, the very effective part, you see it still maintains the higher percentage in comparison to the other antibiotics that are present. Effectiveness, just with the patients who are told to us, when they were asked about just effectiveness, we were at 18%. But then totally, you can see the patients who said that the drug was less effective was only 8% when it comes to Zetromax, azithromycin, as in comparison to other antibiotics. Another infection that is really troublesome to us is pneumoniae for patients. And you're looking for something that is very efficacious and has good recovery rate. Zetromax is associated with significantly higher survival rates in pneumonia patients. So this is our graph showing that Zetromax, when it comes to survival rates, and when there's no azithromycin in the picture, you see the survival rates with Zetromax are better. Another main fact that we tend to look at, I'm sure as pharmacists, is the discontinuation rate. You'll find that many people don't finish the antibiotics, which is more often than not. The people, once they start, they discontinue the antibiotics because of incidences of related side effects. But with Zetromax, it has less side effects to the patient because of its long half-life, but its short course therapy. So with Zetromax, it is well tolerated with significantly very low discontinuation rates. We have Zetromax Tabs. Our dosage for Zetromax Tabs is very convenient. So with convenience comes efficacy, comes compliance, and with this, we just say you just give Zetromax as a tablet. The Zetromax Tabs is 500 milligrams. That's an OD dose for 3 days. But the beauty is that it's just not only for 3 days, but it stays in your system for up to 10 days because of its long half-life of 68 hours. This is just this is from Pfizer as well. Not only are we in the outpatient setting, we have Dalacin in our outpatient setting and Zetromax, but also in the inpatient we have Meronem, Tazocin, Zavicefta, and Tigersil, which are all Pfizer products with efficacious and good quality to your patients. Whereby we will have more talks where we can go deeper and deeper in this for our other sessions that will be joining you. With that, for me, it's a thank you from Pfizer for giving us your time in this. That comes to the end of my presentation and throwing it back to Bao. Hi, Bao. Hello.
Hello, Lavender. Thank you very much for the wonderful presentation. Now we go directly to the question and answer. And hope you're there. Hope Christian from Pfizer is there. Dr. Dorothy Aywak, are you there with us?
Yes, I am.
Yes, I'm here.
From one of your from one of your presentations, Dr. Aywak, there was a question why ceftriaxone was up. Will you probably respond to that?
Okay, now that what I was presenting is antimicrobial consumption. So when you get your data and you find like that ceftriaxone is up, now you need to go and find out what is the problem in that area. Why are the prescribers preferring? You need to communicate. Why are they preferring to use ceftriaxone? So now you need to also think of, you need to make a decision. Do you need to restrict the use of ceftriaxone to specific areas, or are you going to say that you're not going to be having ceftriaxone? If you're in supply chain, you need to ask yourself, are you failing to provide the other options, and therefore everybody, the only thing that's available in terms of what you avail to, the commodity you avail is only ceftriaxone. That's why the consumption is up, that people can only believe that that's the only item that is available. Yes. So when you get data on how it is you're using the antibiotics, it should prompt you to start thinking, what decision do you need to make? what managerial activity do you need to do? What do you need to teach people? I hope that helps to respond to that.
Asante for that great response, Dr. So the other question is, how can a retail pharmacist change the pattern of prescribing by physicians? Dr. This now goes to you, answering it from a hospital pharmacist. How do you change the prescribing patterns of your physicians? And probably if you are placed in a community pharmacy, how would you change the prescribing patterns of the physicians in the community pharmacy, Dr.
Here, I'd have to start by asking myself, how do I start to engage them? That means communication. Is there a way I can be able to communicate with the physicians who I routinely serve their prescriptions? Is there a forum? Are they, like now you could be in I'll give an example, maybe you're in Upper Hill Medical Center and the prescribers are around there. Is there a forum that you get together? And then you can be able to share. I've noticed you're having a lot of prescriptions for lavender Zetromax. Has Lavender told you that you must prescribe a lot of Zetromax, or just get an understanding of why is it that that is their preferred choice? Also find out, are they using any guidelines to guide their choice of antimicrobial? So for those who are in retail sector, it can be a bit difficult because you might be having quite a wide range of physicians to deal with. But can you find, because there has to be a champion, there has to be somebody who they listen to, who is the thought leader in that area, so that when they speak, then now you see a change happening. So can you be able to identify the thought leader there? Because there has to be somebody who they tend to listen to. Or do you want to take that opportunity to attend some of the meetings of maybe Kenya Association of Physicians and interact with them and probably share? Like I want to hope that Pfizer also has similar sessions with the physicians so that we can share from your practice setting. This is what I'm seeing. What is the reason for that? Is there a way that we can offer care better? Is there some rules that we can adhere to in terms of prescribing? Should I find that you're only, like all the patients who come to see you are coming for only one drug? How is it that you want me to best communicate to you that we need to look at, is that the best choice for that patient? And to hope I've responded to Sorage.
Asante for responding to Dr. Soreja Guerral's question. So, Lavender, just before you switch off your video, Lavender, what is the best time for administering azithromox? Is it before meals or after meals?
Thank you for that question, Bao. And I'm sure this is an area where people need a lot of clarification. With Zetromax tablets, we recommend that it should be given preferably 1 hour before a meal or 2 hours after a meal. That is with the Zetromax tabs. But when it comes to the Zetromax suspensions, it can be given with or without meals. I hope I've fully answered that question.
Okay, asante sana. Thank you very much for responding to that. Another question, Dr. Aywak, this reverts back to you. With COVID, the dry coughs and requests for Zetromax are soaring. In regards to AMS, how do we deal with this? Are there other symptoms apart from fever that to look out for to justify dispensing?
Actually, I have to say now here, Dr. Elizabeth, maybe I would want to ask either others in hospital facilities, because Zetromax behaved, or rather the response of patients. Hello?
Yes, I can hear you, Dr. Aywak.
Yes, the response of patients on Zetromax, it seemed to somehow, for a number, just basically from patient reporting, that it seems to have eased the symptoms and severity. So I can't say that I have any data to support that. But when from the patient reports, particularly when the patients are health workers, so it becomes very difficult how to deal with that, because it translates to the community setting, because we leave hospital and find that it is working somehow, and then you say the same thing, you encourage its use in community practice. So I don't know the others who are in hospital, like see Dr. Bindi is here, Dr. Jaimini, Dr. Banis, if they have any interventions that they have put in place, because unfortunately in the public setting, if it is prescribed, and they it seemed to have been working for the patients, or maybe because it's viral, they were resolving. We can't really be too sure. How is it that they have been dealing with it? So I'd like them to assist. There are a number of questions about the presentation. I think, Bao, I sent you this presentation much earlier, so I think if Pfizer is agreeable, you're free to circulate the presentation.
Asante, Daktari. Now, as you've mentioned, Dr. Bindi Tank is here to assist you in responding to some questions, Dr. Aywak. She apparently has a question for you. She's requesting you to kindly comment on the role of having an antibiogram in defining empiric prescribing.
Yes. Now, that's in a hospital setting. You collect data. The lab collects data on the resistance pattern, and that is what is helping us to come up with empiric guidelines. Now, for those who are in community setting, you see now the antibiogram you generate in hospitals is hospital specific. So you develop guidelines for those who will come to your facility. So you will not pick the guidelines of KNH and apply them to maybe Bagathi, because we're expecting the patients who are coming to us have already passed through Bagathi. So we'll be seeing, when we do the culture and sensitivity, we'll be seeing something different. But the ones coming to Bagathi are coming straight from community. So what we need to do is, even as hospitals, before we start any therapy, maybe we work at making sure that the antibiograms that we generate are representative of communities. I'm trying to look for where that question of Dr. Bindi is. A representative of community, so that can guide even those who are in community sector, if they can be able to identify what could be the potential infection, then they can be able to see what is the best choice. Yes, the role of having, yes. So an antibiogram is important. It is key. There's also some questions which I'd seen here regarding why was tazobactam high. So I'm glad that that was noted by quite a number of you, and I'm suspecting maybe a number of you are from the hospital setting. You have to think, when you come up with policies, if you're in regulatory, managerial, when you come up with policies, your policy is going to end up affecting your consumption of antimicrobials. So for example, for that scenario, there was a restriction that to reduce the use of meropenem. And now the prescribers will jump ship to tazobactam. So when you're coming up with the interventions, the actions and interventions that you're going to use as a steward, is it going to drive the use of a different antibiotic? It's almost like when you try to close a tap in a pipe that is leaking. If you try to close one, you're increasing the pressure elsewhere. So now you find water is leaking at a much higher pressure in that side. So you need to check, when you're putting your restriction policies, what is the effect of that? Are we seeing now suddenly that's made everyone use ceftriaxone, and therefore the consumption is high, so that we can go check what is our baseline, what has changed because of the interventions we've put in place, and how can we educate that, because the message should be, use an antibiotic only when you need. And when you have to use an antibiotic, what is the best choice? So what do your guidelines say? And for community sector, where you probably would not have we now try and see, how do we encourage a collection of data? I've seen at least we have those even in policy and making, like Dr. Eunice. What is it that we can do at that level to be able to establish policies that can help and even guide those who are in community practice to be able to support antimicrobial stewardship? What can we do for those who, our marketers, how are they, what you're promoting, how have we classified them, and who are we targeting to know to make sure that they use them rationally? I think I was trying to answer some of the other questions in the chat. I hope the initial question is answered for Dr. Bindi.
Yes, it's well answered, Dr. Aywak. So probably to Nzioka Christine from Pfizer. Has Pfizer found if Zetromax has positively affected COVID patients worldwide? And you probably have a report on this. Can you share it?
Gitao, Zetromax is not licensed for the treatment of COVID, and so we do not have any such data.
Asante for the precise response. So I'm looking for any other question, apart from those who are requesting to be sent the presentation. I will be able to send you, I'll be able to send you the presentation on my email, on your email addresses. Also, there's a tool that Dr. Dorothy has sent. There's a link on the messaging that Dr. Dorothy has sent. So from Jane Wanjiko, she's asking, can PP be set up by permanently revoking approval of brands that have been analyzed and found suboptimal? Dr. Aywak, probably you can guide us. Can this be a regulatory approach that can be used?
Sorry. Yes, in fact, that's why I was hoping that we have those from various sectors, that if we have those from regulatory, I can't quite pick them out very quickly. If we have those from regulatory, maybe I'll push this to Dr. Eunice Gatito, because I'm sure she interacts with them. That if we, from this, can we, from what data we send, can we generate, can we be able to push a regulatory from the regulatory aspect? And I think this will really even help those in community practice, because they will not have to feel like isolated. There's a bit of protection if you're working in hospital because it's a big organization, but those who are in retail, you might be the only steward and you start wondering whether it's worth it to be the good antimicrobial steward. So if we can have the push coming from the top, that would be awesome to support stewardship. There was somebody who had asked about if you could just momentarily just stop sharing your screen and share the screen of where you can get free learning as you ask the other questions.
There is a response from Dr. Eunice Gatito. She says that she'll share with me the Kenya Essential Medicines list to guide participants on the aware categorization. So I'll be able to share with the participants the aware categorizations from the Kenya Essential Medicines list, and also with the permission from Pfizer to also share Dr. Aywak's presentation.
Okay. For the one who was asking about the free courses, these are examples of where there's FutureLearn. If I said it too fast, you can look for this FutureLearn. It has some course on antimicrobial stewardship. There's also this BMJ learning. You can also get, if you can just even Google, it's a simple Google of free courses, or you could pay for them. Then on the tool, this is the tool. I hope that is clear. Somebody had asked about how measuring consumption. So ideally, this you will do at pharmacy level. It's a pharmacy data. So you will not tell the prescribers to measure consumption. No one will take the time to do it. And it is a bit, it takes a bit of time to be able to learn. Maybe we can, because we can learn and teach each other. We can maybe get in touch and we can share how we've been using this tool to be able to calculate consumption. Thank you.
Asante for that response. Asante. And Dr. Eunice Gatito also comments and says that we have the National Medicines and Therapeutics Committee that is supposed to give oversight to counties and health facilities on antimicrobial stewardship, among other roles. We are already working on various documents in collaborations with hospitals and county participants. So probably for those in the hospitals, you should be on the lookout for these documents once the rollout is initiated. And probably from our end at Pharmaceutical Society of Kenya, we're going to ensure that we share with you some of these documents once they get to us. Dr. Aywak, probably this is the last question for tonight. Judy Chelangat asks, what are the antibiotic stewardship badges?
The antibiotic stewardship badges?
Yes.
Budget? How much money or what? Sorry, I didn't get that question. The budget allocated to antimicrobial stewardship.
Badges, BADGES.
I think I am missing. Badges. What are the antibiotic stewardship badges? That one I am not familiar which badges those ones are. Maybe I know them by a different name.
Yes.
Or do you mean the what are that one? Unless somebody, I know there are quite a number of stewards here. I'm not familiar with the antibiotic stewardship badges. Whether is it that when you've scored
probably on your poll question, on your poll question number 4, that you'll have answered as
it's a little Greek.
It's a Greek. So, Judith, I will request you to kindly share your question again. If we are not able to respond within the course of this webinar, we'll be able to get back to you via email. And David Disho comments that Kenya Essential Medicines list developed by the National Medication Therapeutics Committee is not implemented by TIRE system used in public health service. How does it get strengthened? So that is a question to all of us, probably all who are practicing in the hospital setup, those who are in policy. Dr. Yudis Kaditu, thank you very much for responding to the questions tonight. And also, Dr. Aywak, being able to sit in some of these committees, how are you going to ensure that it's going to be strengthened? That is just a take home for us. So without further much ado, Dr. Dorothy Aywak, I give you 1 minute to probably give us your parting shots.
I'd say the parting is the slide that I said, that knowledge that you don't apply is just as useless as paint that you don't put on the wall. So I would want to hope that we've actually picked something, all of us, and regardless of which sphere you're practicing, there is at least one thing, there's at least one point of the star you're going to be able to apply. So, and also reach out. I'm seeing we are quite a number here. Reach out to others if you're stuck in implementing or in starting up. Just encourage you, let's communicate, let's reach out and help each other to be good stewards of antimicrobials. Thank you.
Asante sana, Dr. Dorothy Aywak, for your time. Lavender, what is your parting shot for tonight?
Thank you, Bao. My parting shot for tonight is urge you as pharmacists to take up when it comes to choice of antibiotics. Look at efficacy, look at quality, look at compliance when you're issuing, when your choice of antibiotic comes to mind. And with Pfizer, we are here with you to work with you in regards to any questions, any support, and we thank you for your support as well. Thank you.
Lavender from Pfizer, and Zioka Christine, asante sana for your contribution tonight and for the efforts that you've made to ensure that we have a great webinar tonight. Probably a word from you, at least from the lady boss herself.
Oh, okay. Yeah, thank you for making time to attend this forum today. Despite the fact that you've seen we are the Meronem people, we have the brand piperacillin tazobactam, and Dr. Dorothy showed some slides that showed, some in specific institution or hospital, some spikes. What I'd like to mention is that Pfizer supports rational use of antibiotics. And as when Lavender was beginning her presentation, she mentioned we do not promote the use of any of our brands in anything other than the licensed indications. And so be rest assured in that. And that is why we are actually sponsoring a meeting on rational use of antibiotics or antimicrobial stewardship. I'd just like to mention that I saw somebody who had asked about tigecycline, and there were other questions. Of course, we'd be able to handle them. Maybe the time was short, but reach out to our representative who comes around you, and they'll find somebody to answer the questions that you had, if they cannot answer them themselves. So thank you very much, and we hope to do this again with you in the critical care antibiotic setup. Thank you, Mbao.
Asante, Christine and Zioka from Pfizer. So ladies and gentlemen, as you all know that PSK has endeavored to ensure that it is empowering the young pharmacists to take over the mantle of the practice of pharmacy. And with that, there is a program known as Pharmacy Graduate Trainee Program. And we have an intern with us tonight. I introduced her to you, members of the noble members of the society, or seniors of the society. I introduced that to you some time back. So allow me to welcome Dr. Ivy Retemo to be able to close for us today's webinar. Ivy Retemo, are you with us?
Yes, Mbao, I'm here with you.
Karibu sana, and kindly close the webinar for us, Ivy.
Thank you, Mbao. Thank you so much. First and foremost, I'd like to say a big thank you to Dr. Aywak Your presentation was very informative. And I feel like this data should get to even we, the young pharmacists who are just joining the field. Secondly, I'd like to say a big thank you to our sponsors, Pfizer, asanteni sana. Thirdly, to the participants, the session has been very interactive. I'm very grateful. You have answered questions on the poll. You've been very interactive in the chat section. I do not take it for granted. It's good. It shows that we're all learning. Last but not least, I'd like to pass my regards from our National Executive Council, from our President of PSK, Dr. Louis Mashogu, and our CEO, Dr. Daniela Monene. And for those who are asking, I've seen a few questions on the chat box. The recorded session will be uploaded on the PSK YouTube channel. Other than that, good night and asanteni.